Welcome to part 1 of Stroke Savvy, Nursing and Physician Insights. My name is Pam Stout. I'm the Nurse Practice Coordinator and the Stroke Coordinator for Methodist Fremont Health. We have Alex and Megan with us today.
Hi, I'm Alex Stunkard. I am the Stroke Program Coordinator for Methodist Hospital and Women's Hospital.
And I'm Megan Gertis. I am the Service Leader of Primary Stroke Unit and a Med-Surg Unit, and also serve as a Stroke Coordinator for Methodist Jenny Edmondson.
So today we're going to take you through Tony's journey. Meet Tony. He's a 53-year-old husband, father of 3, who was just enjoying a day on the golf course with his college fraternity buddies. As they approached hole 9, things took an alarming turn. Tony's friend Mike first noticed that something wasn't quite right when Tony seemed to struggle with placing his ball on the tee and appeared to be off balance. Mike thought it might just be the effects of a few drinks, but as Tony went to swing, it was clear that to everyone that something was seriously wrong. Concerned, Mike asked Tony if he was feeling okay, but Tony's response was hard to understand. His words were slurred, and it became obvious that something was more serious than just a few too many beers. Tony's friends Arnold and Jeff quickly noted that on hole 8, Tony had been stumbling when getting into the golf court and seemed to be leaning a little bit to one side. That's when Jeff suggested they should just head to urgent care, but Arnold thought Tony just needed to cool off in the clubhouse. It wasn't until Mike checked the time, 11 o'clock a.m., and he voiced his growing concern that Tony just might be having a stroke and suggested that they call 911. So EMS arrived promptly, quickly assessed Tony using a well-known stroke scale. Let's take it from there. Alex, can you start us off by explaining what the Cincinnati Pre-Hospital Stroke Scale is?
Yeah, sure. So the Cincinnati Pre-Hospital Scale is a scale that EMS utilizes to identify signs of a stroke. So they focus on 3 key areas: facial drooping, arm weakness, and speech difficulties. And if any of these signs are present, it raises suspicion that stroke might be occurring, and allowing EMS to act quickly and promptly and get them to the help they need.
Special guests joining us today include Dr. Michelle Williams, Dr. David Franco, and Dr. Jennifer Harney. Can each of you just take a moment to introduce yourselves, your medical background, and your involvement in the stroke program?
Hi, I'm Michelle Williams. I've been an emergency physician for about 20 years, working in the emergency rooms that whole time. Had some different environments in the city and in the rural areas. Currently, I am at Methodist Fremont Health as the director of that emergency department. I've been in that role for a little over 4 years, and I am also the stroke medical director for the past 2 years since we decided to create an acute stroke ready hospital at our facility.
And I'm Dr. David Franco. I'm the a neurologist and stroke director at the Methodist and Women's Hospital. I've been in practice almost 25 years and been in the stroke director role for about 10 or 11 years now, and have both outpatient practice and also neurohospitalist duties at the main hospital at Methodist.
So based on the positive findings of the stroke scale, Tony was transported to the emergency department. They called ahead to notify the ED about the potential stroke en route, which is referred to as a stroke alert. Dr. Williams, can you explain what exactly a stroke alert means when EMS calls ahead?
Sure. So a stroke alert is when we hear from the pre-hospital. This could be our city ambulance or our rural ambulance providers calling ahead to tell us we have a patient here that is displaying stroke-like symptoms based on usually their assessment is the Cincinnati Stroke Scale. So they're giving us time to prepare for the patient to come so that we can have everything ready, our nursing staff, our physicians, our respiratory therapists, and our radiology department ready to go to care for this patient right away when they come in the door.
Why is it so important to know that a potential stroke is on the way?
So time is really important in the care of stroke patients. The sooner we can intervene, the better the outcome for the patient. So knowing that a stroke is on the way allows us to activate our stroke protocols in advance, getting ready to take care of them, getting them to imaging, and getting treatment started earlier.
In this case, Mike felt it was necessary to call 911. Jeff suggested that they could drive Tony directly to urgent care. How does the mode of transportation impact the care that Tony receives?
So in this case, with the patient coming to the hospital by ambulance, there's two things that are really important. The first is that that team on the ambulance can start care for the patient right away. And then the second thing is that the patient needs to get to us as soon as possible because time is important. So if they had gone to urgent care first, that would add another delay in the time in getting to the emergency department.
Now let's fast forward to when Tony arrives in your emergency department. What happens next?
So patients that come in by ambulance that we've received the stroke alert from EMS will be a stroke stop in our emergency department. So they'll come in, they'll stay on that EMS cot while we do a quick assessment within the first 5 to 10 minutes of the patient to determine if we still think this patient is a potential stroke. And then we'll get that patient right to the CT scanner where we can rule out other causes such as hemorrhage and also to confirm potential ischemic stroke so that we can start treatment as soon as the patient gets back from radiology.
Why is the CT so important?
So the CT scan, it allows us multiple things. The first is to determine if the patient has a hemorrhage, because if they have a hemorrhage, then they're not going to be a candidate for the thrombolytic treatment. And then the second is to look at if we can actually see the signs of the ischemic stroke on the various scans that we do.
Now, I know somebody had said that it's really important that we check blood sugar after a stroke or when somebody comes in. Why is that so important? What does that have to do with it?
So a low blood sugar can mimic a stroke. Many of the times our EMS will have already done a blood sugar for us, but if not, that's the first thing we do when they come in as we're rolling the patient to the CT scanner.
Dr. Williams, can you walk us through what your assessment includes once that patient comes to the emergency department?
Yes, so our assessment for a stroke is going to include the NIHSS, which is the National Institute of Health Stroke Scale, and that helps us to determine the severity of the stroke symptoms. We are also going to get a thorough medical history, things like the patient's past medical history, medications, recent procedures or surgeries is going to help us to determine possibility for a stroke as well as possibilities for treatment for them. Also, many of these stroke patients can't adequately communicate with us, and so getting in touch with friends or family to get further history and also to talk to them about treatment options is important. One of the big things that we need to determine is the last time known well, because that determines if the patient is going to be a candidate for thrombolytic therapy. We need to be within a 3 to 4.5 hour window to be able to administer those thrombolytics.
So we hear that Tony had been drinking earlier in that day. Could his symptoms have just been related to drinking too much?
Certainly, alcohol, other medications or other drugs can mimic stroke-like symptoms. But the important thing for us is that we are not dismissing these symptoms as just because of that, but looking for the worst case scenario, looking for a possible stroke, and especially because his symptoms were worsening and severe, we need to consider the possibility of stroke in him and not delay any of our stroke assessment because of something else that's going on.
So you said that you take them straight to imaging and to CT. If the radiologist calls and says it's a clear CT, what does that mean?
So our radiologists have an alert flag that we need these CT scans on these stroke patients read right away. So we're going to get a call from them pretty quickly to say whether there's something that they find or whether it's a clear CT. Clear CT tells us that there's no hemorrhage, so there's no bleeding, and also tells us that there's no other abnormality on the CT scan that would explain what's going on with the patient. This means it's likely an ischemic stroke, meaning a blockage in the blood vessels, causing blockage of the blood flow to the brain. So in this case, we know it's an ischemic stroke. We can go ahead with our therapy for that, and we can go ahead with thrombolytic therapy because we know that there's not a hemorrhagic stroke.
Dr. Williams, at what point do you know when to involve neurology specialists?
So once I've done my initial assessment of the patient, the imaging has been done, and I've gotten that call from the radiologist about the results of the initial imaging. Then I may consult with the neurologist to say, here's what's going on with the patient, here's the symptoms, here's my examination, and then that neurologist can also directly view the imaging for the patient. We can make a decision together. Is this patient a candidate for thrombolytic care? Is this patient appropriate to stay in my community hospital, or does this patient need to be transferred to a more comprehensive stroke center?
So you mentioned that there are treatment options for ischemic stroke, such as thrombolytic therapy. What other options are there?
So again, we talked about thrombolytic therapy needs to be administered within 3 to 4.5 hours. Some candidates are not, some stroke patients are not a candidate for that based on timing or also based on other risk factors. Patients that present within 24 hours can also be a candidate for a mechanical thrombectomy, which we would transfer the patient to a center that is capable of doing that. Patients that are not candidates for thrombolytic therapy or for a mechanical thrombectomy would then be treated with medical therapy alone.
Dr. Franco, as a neurologist, can you explain what thrombolytic therapy and mechanical thrombectomy mean?
Sure. So thrombolytic therapy is the administration of a drug through an IV that is designed to dissolve the clot within the blood vessel that is causing the stroke, and that needs to be done within the 4.5 hour time frame, and the sooner the better. Mechanical thrombectomy is reserved for a situation where the patient has a large vessel occlusion or a larger stroke that we think there might be an opportunity to go and retrieve the clot out of the vessel. So to do that, if the patient is a candidate, then we would administer catheter through the groin or through the arm, through an artery that goes up into the area involved, and then the clot is either dissolved or retrieved, and to relieve or to restore blood flow back into the brain.
Dr. Franco, what role do you play in determining whether a patient is a candidate for thrombolytic therapy and or mechanical thrombectomy?
So we work with our ER colleagues to first decide, is this a stroke, and is this something that might be a candidate for therapy, either thrombectomy or thrombolytic therapy. This involves assessing the patient with basic history and examination, but also assessing all of the laboratory and imaging data that we need. Additionally, we have to be sure about the time frame of when the stroke started, and again, for thrombolytic therapy, this needs to be within 4.5 hours or 4.5 hours. For mechanical thrombectomy, we have up to 24 hours to do this, although again, we certainly want to initiate treatment as soon as possible in either situation. The other aspect of it is making sure that the patient doesn't have a contraindication to the therapies. Do they have a high risk of bleeding or an abnormality on their blood work that would make the therapy too dangerous or not appropriate to administer at that time?
So Dr. Franco, if Dr. Williams calls you from Fremont and you're in Omaha, how quickly can you actually review the imaging if you're not present in the emergency department?
Yeah, we can really have quick access to the images through the technology we have nowadays. First of all, I get a stroke alert or a page that basically tells me that there may be a candidate in the emergency room or in the hospital. And so based on that, I will wait to get information from the emergency room colleagues. And at that point, I can pull up imaging within minutes, either on my computer or even on my cell phone, so that they can be reviewed promptly and we can make a very quick decision on treatment for the patient.
What factors do you consider when deciding whether to transfer a patient to a higher level stroke center?
Yeah, we basically want to determine whether the patient may benefit from additional therapy or care that the referring hospital might not be able to provide. And so when we're evaluating for that scenario, we are certainly discussing matters with the emergency team. One of the factors that often necessitates transferring to a stroke specialty center would be a patient who is in need of therapy for mechanical thrombectomy. So if they do have that LVO or large vessel occlusion presentation, then that would be something that we would assess, and if they're a candidate, then that might necessitate transfer. We're certainly also going to take into account the stability of the patient, their age and risk factors, and treatment options. And this is a collaborative process. We're discussing this with the referring hospital, and then a decision will be made.
Can you tell us a little bit about what that scoring is and why it's used?
Yeah, so the Tiki score is basically designed to assess how well that vessel is opened up after mechanical thrombectomy. So it's a decision made by the interventionalist based on the angiogram that they see in real time. And so once they've removed the clot, we assess how well the perfusion has been restored. And the lower grades, like a Tiki score of 0, means there's been no reperfusion. Grade of 1 means there's partial perfusion, meaning it's just past the clot, but we really haven't achieved blood flow in that territory. Then we go to the grade 2 scores, and grade 2A is where we achieve perfusion in the territory, but about 2/3 or less. And then beyond that, we can get the Tiki score of 2B, which means that we do have good perfusion throughout the territory, but it's slower than normal. And then the grade 3 would indicate normal perfusion. Some providers also use the grade 2C, which just further grades that we're nearly perfect perfusion, but there may be still a couple of defects within the territory.
Dr. Franco, you mentioned that when you look at imaging, and I understand that there are 3 different types of CT images done when a patient is being worked up for a stroke. Can you explain those 3 imaging capabilities to us?
Yeah, so the first one is really just the plain non-contrast CT scan, and as Dr. Williams alluded to, that's crucial to make sure that we don't have a hemorrhage or some reason that the patient would not be a candidate or have a contraindication to therapy. However, this may not necessarily show a blockage or an ischemic stroke on the CT. So the additional modalities that we use are the CT angiography or CTA and CT perfusion scan. The CT angiography will give us a picture of the blood vessels where we can actually see a blockage within the blood vessel, and this was very helpful in determining patients who might be a candidate for mechanical thrombectomy. The CT perfusion gives us regions of the brain that are not receiving blood flow as well as expected, and we compare to the other side. So we use all these modalities to help make a decision on whether the patient's a thrombolytic candidate, mechanical thrombectomy candidate, or both.
So let's shift back to Dr. Williams. Can you tell me a little bit about the process of actually administration of thrombolytic therapy?
Okay, so once we determine we have a patient who we believe has an ischemic stroke, we've done the CT scan without contrast to determine that they don't have a hemorrhage, then we need to look at the whole picture of the patient to determine are they truly a candidate for this thrombolytic therapy. We need to look at factors like medications they're on. Certain blood thinners would be a contraindication because those can increase bleeding. If they have a past medical history that would indicate bleeding disorder or something else, that would be a contraindication. And then also any recent procedures like a recent surgery, that would be a contraindication because they could have severe bleeding with that. If they don't have any contraindications, then we need to have a discussion with the patient or family about the risks and benefits and determine if the risks of bleeding would outweigh the benefits of decreasing the symptoms and the severity of an ischemic stroke. So we'd have that conversation with the patient if they're able. If the patient is not available, then we would have that discussion with the patient's family. If the family is not available either in person or by phone, then we would determine that potentially we need to do this emergently based on our best clinical judgment.
So when you mention consent, does the patient or family need to sign a consent to get thrombolytic therapy?
So because the thrombolytic therapy is a standard of care treatment, after we have that discussion with the patient or family, then verbal consent is what we use for consent in this case.
So thrombolytic therapy, we keep talking about thrombolytic therapy, and what are the medications?
Yeah, so the 2 common thrombolytics are alteplase and tenecteplase. Methodist Health System actually just switched from alteplase to tenecteplase, and those are the most 2 common.
So what was the big thing? Why did we switch?
Yeah, so alteplase essentially was a bolus, and then it was followed by a drip, whereas tenecteplase is a single bolus. So it's really helped kind of cut down on our times for that.
Okay, all right. So you have an order for it. Then what happens?
Yeah, so once we get the order for it, what we'd want to do is give pharmacy a call and say, hey, we have an order for this IV thrombolytic. And what pharmacy is going to do is they're going to verify the medication. They're going to make sure that we have an actual weight documented, because IV thrombolytics are weight-based medications. So they're going to verify that drug, and once we have verification that everything looks good, then we are okay to go ahead and administer.
So you talk about weight-based. Is that a weight that we just ask the person how much they weigh? What do you do?
Must be a physical, actual weight that you do right on admission.
Okay, all right, okay. So you have your thrombolytic therapy order. It's come in. It's been verified. Their blood pressure is below the 185/110. What next?
Yep, so the nurse is going to grab a buddy. They're going to have 2 people in there to draw up the medication together, and they will draw it up and administer it in the room together, and it'll be a dual sign-off. So you flush with 10 cc's of normal saline, you give the bolus over 5 seconds, and then you flush again with another 10 cc's of normal saline.
So, Alex, we were talking about how Tony received IV thrombolytic thrombolytic therapy. As the stroke coordinator at Methodist Hospital, can you just kind of tell me a little bit about what nurses need to know about the administration of thrombolytic therapy?
Yeah, sure. So they're going to continue with that every 15-minute vital signs, full neurological assessments, and then they want to ensure that they have an NIH completed and documented prior to the administration of IV thrombolytics.
Okay, so when you talk about the vital signs, what are they looking for?
So prior to starting that, you want to make sure that you have a blood pressure less than 185/110 prior to starting that.
So if it's greater than 185/110, how do we treat that?
So our first line treatment that we're going to try is labetalol. We can try labetalol up to 2 times. If that's not working, then we want to go ahead and try a nicardipine drip.
Okay. Any other blood pressure meds that they could use, or why is it just those 2 meds that we have on there?
The clinical practice guidelines support those 2 medications. If there were specific patient contraindications, they could try other means of blood pressure management.
Okay. So if somebody's elevated and we give this treatment, how soon after we give a treatment do we check it? And when is it then okay to give?
Within 5 minutes, you're going to want to recheck that blood pressure, and you can give the labetalol every 10 minutes.
Okay. All right. So you've got the medication in.
Mm-hmm.
What does the nurse need to do to monitor this patient? Because it sounds like it's a high-risk medication.
Yeah, so since it is a high-risk medication, they are going to continue with those every 15-minute vital signs and neurological checks for 2 hours. Then it will switch to every 30 minutes for 6 hours. And then it's going to be every hour for 16 hours. And they're going to be admitted to the ICU. And they will be monitored in the ICU for the next 24 hours following this medication. Another key thing is once we have given the medication, we want to maintain that blood pressure less than 180/105 for the next 24 hours.
And if they go above 180/105 in that time period, does it go back to the medications again?
Yep, we're going to use the same medications to treat. We have labetalol times 2, and then we also have nicardipine that they can use.
One thing that I don't think we touched on earlier is there a time frame? Is there something that we're looking at? I know they talked about the fact that it needed to be given within 4.5 hours of symptom onset.
Sure.
But once they come to the hospital, how soon do we need to give IV thrombolytic therapy?
Yeah, so what we look at is what's called a door-to-needle time. So that's the time that a patient arrives into our ER, and then how fast we are giving that thrombolytic. So what we shoot for in the ER is we want to have a time less than 60 minutes that we're giving that medication.
Can you tell me, you talk about it in the ER, what happens if a patient has a stroke in the hospital? Is it the same time frame?
Yep, so we're going for the same time frame, and what we like to have is the inpatient side kind of mirror what happens in the emergency department. So the door time essentially is the time that RN or whoever's in that rapid response role enters the door.
Dr. Franco is a neurologist. I'm assuming that you would take over once they're in the ICU after they leave the emergency department. What are some things that you would want to be notified in that first 24 hours after we administer thrombolytic therapy?
Yeah, so once the patient has been administered thrombolytic therapy, we want to watch closely because there is a higher risk of complications shortly after we administer therapy. So we want to make sure that we're monitoring for any change in their neurological status, which could be worsening weakness or more difficulty with speech or alteration in awareness or alertness. And during that time, we're also being careful to monitor for bleeding complications. We've just administered a drug that can help dissolve clots. So those would involve areas of the body that might be developing hemorrhage outside of the brain, as well as for complications that occasionally or really uncommonly occur, which includes angioedema or an allergic type reaction to the medication.
And Alex had talked about how the patient's in the ICU for at least 24 hours. What's so special about that 24-hour mark?
Yeah, during the first 24 hours, we feel like we have a period of time where the risk is highest, but once we achieve that time window, then the effect of the medicine is diminished, and we feel like the patient can be less likely to experience complications. So at that 24-hour point, we will repeat a CT scan and make sure that there isn't any hemorrhage or complications in terms of the brain imaging. And then if that returns as negative for hemorrhage, then we can proceed with treatments, including aspirin or other blood thinners that might be appropriate to use at that point in time.
So as we shift from what occurs in the emergency department, we're going to shift to what happens after the patient gets admitted. For this portion, we have Dr. Harney, who's from Methodist Jenny Ed here. Dr. Harney, can you just take a moment and introduce yourself?
Sure. So Dr. Jennifer Harney, I was originally primary care and transitioned to full-time hospitalist role at Jenny Edmondson about 2.5 years ago, and got involved in stroke care with Megan about 2 years ago and have been on the stroke committee since that time.
Well, thank you so much for coming in today. Can you kind of walk us through what the workup for a stroke patient is once the emergency part is done?
Sure. So once a patient comes upstairs after the initial workup in the emergency room, we kind of want to start a multidisciplinary approach for this patient. That usually starts with entering the appropriate order set so that care is somewhat standardized and we're not missing anything. And then from there, we usually start pretty frequent neurologic checks. So we want to make sure a patient isn't showing new signs of a new deficit. So it's really critical that nurses are doing those frequent checks once they're up on the floor.
Okay. So we've talked a lot about the blood pressure management prior to giving IV thrombolytic therapy and what we look for following it. From a physician standpoint, can you just kind of tell us a little bit about why blood pressure control is so important?
Absolutely. So like you said, blood pressure control is really important both before and after thrombolytics are administered. If a blood pressure would remain too elevated after thrombolytics are given, that risk of hemorrhagic transformation or other bleeding in the brain is much higher. So we really want that strict blood pressure control that could include extra PRN medications, and sometimes we'll reach out to our neurologist colleagues for really specific guidelines on what to follow there.
Okay. So the blood pressure management for thrombolytic therapy, I understand, is 185 over 110 prior, 180 over 105 after we give it. What if somebody is not a candidate for IV thrombolytic therapy?
Good question. I actually thought about talking about this outside of our case with Tony. So if somebody comes in with an ischemic stroke, but they don't qualify for thrombolytic therapy because they're out of that 3 to 4.5 hour window, we actually prefer to allow that patient's pressure to run a little higher than we might typically with a regular med-surg patient. And that makes sense, right? Physiologically, part of the brain isn't getting as much blood flow as it normally would. So if we try to lower that pressure more aggressively, we could worsen that area of poor perfusion. So we allow some permissive hypertension for those patients.
What are some lab orders or other diagnostic tests that are just part of the workup for that stroke patient?
Yeah, so once a patient's admitted, I tend to order several labs and a few diagnostic studies. Depending on the stroke type, we may look for bleeding disorders or clotting disorders. And then every patient always gets a cholesterol panel. We know that high cholesterol can increase stroke risk, so we want to find that right away if we can. The other lab we always get is a hemoglobin A1C to screen for diabetes. We know that diabetes increases our vascular disease throughout our whole body, right? And our brain is included in that. So if a patient has diabetes, we want to make sure we find out about it so we can address it right away. We also order a couple other tests that aren't labs necessarily, but an echocardiogram. So an ultrasound of the heart with a bubble study, that's to look for atrial fibrillation as well as PFO, so a patent foramen ovale, which after we're born normally closes. That's that hole between the right and left sides of the heart. But if it remains open, that can increase the chance that a blood clot could go through there and fly up to the brain and cause an ischemic stroke.
Somebody comes in as a stroke, what are some things that we need to be thinking about as nurses from a standpoint as can they swallow? What kind of things do we need to think about?
Yeah, absolutely. So a lot of patients are hungry when they get up to the floor. They're asking to eat or drink, but sometimes after strokes, our swallow muscles are pretty significantly affected. And it makes it a lot easier for something to go down the wrong tube. So our risk of aspiration, choking, pneumonia is much higher. So I'll place an NPO order, and then I really try not to let that patient eat or drink until the nurses can do a bedside swallow evaluation. And from there, if we need a speech therapy evaluation that's more in depth, we can get that going as well.
All right. I also understand from some of the things that I've done how important VTE prophylaxis is. Can you kind of explain what does that look like for stroke population?
Absolutely. So kind of like we talked about earlier, some of that is stroke type dependent. If somebody comes in with an ischemic stroke and they're not a candidate for a thrombolytic, then we'd want to get them both on chemical and mechanical DVT prophylaxis. Stroke-wise, your mobility is really limited, so that risk of VTE is much higher than the general population. So something like both Lovenox and SCDs. Versus if somebody comes in with a hemorrhagic stroke, or they get thrombolytic therapy, we wouldn't want to give them additional blood thinners, at least for a while. So those patients would only be on SCDs or mechanical prophylaxis.
So Megan, once the patient's admitted to the unit or to the floor, what are some of the nursing priorities for care?
That's great. When the patients first come to the unit, one of the nurse's responsibilities when admitting the patient is to kind of get that baseline vital signs. So what is the blood pressure that they're at for the day? And then also frequent neurological assessments while they're admitted to the unit. Again, just to get that baseline if we're allowing permissive hypertension or is this something we just want to monitor closely.
Okay. So when you're talking about your frequent neuro assessments, does that include that NIH stroke scale?
Yes, the NIH stroke scale is included in that. And again, it's just to get that baseline. Are we seeing worsening of symptoms or progressing of lessening of symptoms?
Okay. Do you do a handoff between the emergency department and the floor?
Absolutely. We would love that to be at the bedside if possible. So again, if we're seeing any deviations in care, we want to make sure that those assessments align. So if we can have the bedside nurses together doing that handoff is best practice.
Okay. So what are some of the other things that nurses need to be aware of? Let's think about like education.
That's a great question. Of course, when a patient comes in, we want to look at multiple factors of the why the stroke may have happened. Again, if they're diabetic or any of those other risk factors, we want to start education from the minute they're admitted to discharge. So we want to talk about maybe the risk factors involved and provide that education ongoing. But we will also want to prep the patient for what does their discharge look like when they leave. So again, that interdisciplinary approach of incorporating PT and OT to their rehab and stroke recovery, to speech therapy, to maybe a dietitian and all of those other factors to make sure they're getting everything they need and understand, so they can go back successfully to the community.
All right. Is depression something that we need to be concerned with stroke?
Absolutely. I think that's something that maybe gets often overlooked with these stroke patients. Our nurses perform a PHQ-9, which is a depression scale for these patients, the second day after they're admitted. And that's a screening tool, again, to make sure that they're getting the help that they need. If it's above a level 5, at that point, we do notify the physician, so that way we can get the help that that patient may need.
Do we all, if they score at that 5 or above, do we start something like medication right there? Or is that something that's more of like a baseline for us to continue to kind of watch throughout their recovery?
I think it depends on each patient, and again, at that point, we'd include the provider, depending on the severity of it, and of course, what is their plan on discharge. I don't know if you have anything to add.
Yeah, I could kind of speak to that. So some of the symptomatology can be timeline dependent. We expect this is a big event and traumatic for the first couple weeks, and if symptoms are ongoing after that, that would qualify as a depression diagnosis. So the hospitalist can help kind of facilitate, hey, let's watch for these symptoms, let's communicate with your primary care provider so we can monitor these going forward. And if that means medicines or a referral for therapy later on, we can help with those planning wise for a PCP as well.
Dr. Harney, going back to you, if the nurse during their frequent assessments identifies that there's a neurological change,
Yeah.
what steps should they take?
Would love it if they could page us or give us a call. Typically, we'd want to go to bedside so we could do also a thorough neurologic evaluation of the patient.
I hear that there's things like stroke mimics, and I know we talked about that a little bit earlier, things that we need to be kind of aware of. But can you kind of talk a little bit about some causes that would be considered a stroke mimic?
Yeah, absolutely. So if I'm going to the bedside and there is a change, these are some other things on the differential that I'll be thinking about. But some common things that show up that can cause stroke symptoms might be medications we have the patient on, or hypoglycemia is a big one. Even other things like a complex migraine or seizures or a developing infection or a brain tumor can all mimic stroke symptoms.
Okay. What are some of the priorities that you could share with us when we're discharging somebody who's had a stroke? What are some of the things that we need to be aware of?
So really, we try to start working on discharge planning from day one when somebody enters the hospital. Like Megan was speaking to earlier, we screen for depression symptoms. We've kind of talked about what follow-up for those symptoms might look like, making a note for the primary care provider and thinking about referrals to therapy. Next, we also think about modifiable risk factors that somebody might have that could have contributed to their stroke. So these things might be high blood pressure diagnosis, high cholesterol, we just found they have diabetes, or we just found they have atrial fibrillation, or if they're a smoker. So we know that about 1 in 3 patients after they've had one stroke can go on to have another one later on. So addressing these modifiable risk factors with a lot of education for secondary prevention is really important. Then the last big piece of planning would be around rehab. So we have every patient evaluated with speech, physical, and occupational therapy within 24 hours of admission. If somebody has really high needs because they have a severe stroke, then I'll often be consulting a physical medicine and rehabilitation doctor, and they can evaluate that patient to see if we even need something like acute rehab, or if we're not at that level, skilled nursing care planning or outpatient therapy planning.
What is the goal? Like, is the goal to get them back to where they were at the very beginning before the stroke ever happened? Like, how do we know that that's what we're going to make that?
That's always our goal, I think. Like our case with Tony, we know he enjoys golfing, so for him specifically, it would be our goal to intervene early and aggressively in hopes we can get him back as close to his baseline as possible so he can get back to golfing, because we know that's what he enjoys.
Okay. What are some medications that are generally prescribed to stroke patients on discharge?
Yeah. So I would say common medications, often patients will need antiplatelet therapy, so kind of anti-sticky blood medicine, and this could include aspirin and or Plavix. Those are both pretty common on discharge. Another big one is a statin, so a cholesterol medication. Kind of regardless of what a patient's lipid panel might look like, we know that statins lower the chance of strokes going forward. So most patients should be prescribed a statin unless there's a big contraindication. And then other medications are kind of based on their risk factors. So if we found out somebody has atrial fibrillation, they'll likely be discharging on some kind of blood thinner like Eliquis or Xarelto. And then from there, possibly blood pressure medications. Those are some of the common ones.
Okay. And then when the patient discharges, what resources are available for them?
Yeah, so we've kind of talked about therapy resources and planning to support them therapy-wise. We've talked about emotional support, and then often we have a lot of good community resources available. Like Methodist has a stroke support group that we often refer patients to afterwards as well.
Well, we want to thank you guys for taking the time today to talk us through Tony's journey, give us valuable insights into the stroke care process. From what you guys have said, it's very clear that we need collaboration, timely interventions, and a comprehensive patient care. When that happens, we can significantly impact outcomes for our stroke patients. I think Tony's story illustrates the importance of that quick thinking, early diagnosis, and the critical role of the entire healthcare team. Dr. Harney, do you have anything that you'd like to add?
I think you hit the nail on the head. Just looking at big patient picture, it's not just about the acute stroke that's happening, but looking at the patient as a whole and planning from a multidisciplinary point of view how we can help this patient through what they're going through kind of every step of the way, and then even planning for once they're outside of the hospital. So for Tony, trying to get him back to his baseline as well as we can, and planning support for him once he leaves his care in the hospital.
Okay. Thank you so much, Dr. Williams and Dr. Franco, for sharing your insights. It's clear that stroke management requires that seamless collaboration between emergency physicians, neurologists, and other specialists to ensure that there are the really good outcomes for the patients. Do you have any closing remarks that you would like to share?
Thanks for having me. It is a team effort, and it is great that we can get this information out there and all work together to get timely care to our stroke patients.
Yeah, I appreciate the opportunity and agree that it really is a coordination of multiple providers and service lines to provide this type of care to patients, but with careful assessment, we can provide therapy that makes a tremendous difference in the outcomes of stroke patients.
Thank you so much. We want to thank you guys for joining us today as we kind of took you through Tony's journey. And the insights that the physicians and the nurses have given on the stroke care that we provide to our patients.
Yeah, it's been a pleasure, and we are so grateful to work with such a dedicated team. And if there's one last takeaway, it's be fast.